Welcome back. Today we are going to talk on a new topic, that is premenstrual syndrome. That's a common experience that a lot of women go through during the reproductive days. Around 40% of females experience some form of premenstrual syndrome. If we look at the definition of premenstrual syndrome, it consists of both psychological as well as physical symptoms which are experienced during the luteal phase of the cycle. If you look at the physical features, they experience breast tenderness, abdominal bloating, and also if you look at the psychological symptoms, they experience depression, anxiety, and inability to concentrate, and different degrees of irritability and mood swings. So, in diagnosing this premenstrual syndrome, it should be a prospective diagnosis. We can't diagnose the syndrome retrospectively by talking to a patient about her symptoms. She has to maintain a symptom diary for 2 cycles, approximately 2 months, so that prospectively we can look at the cycle pattern, the symptom pattern, and diagnose this by noticing that the symptoms are prominently appearing during the luteal phase of the cycle. There are small differences, like sometimes these females can be non-ovulatory when they don't have menstruation, but still they will have the symptoms, cyclical symptoms. They will show the cyclical, psychological and physical symptoms. And also we have to, through this symptom diary, we can identify patients who have exacerbation of their other diseases, underlying disorders. It could be physical diseases, it could be psychological diseases. If we look at disorders like epilepsy, asthma, migraine, they also can be exacerbated during the luteal phase. And also there are psychological conditions like depression, which can exacerbate during premenstrual phase. So we have to differentiate between those and correctly identify the true premenstrual syndrome. And also if you look at, when you talk about the etiology of premenstrual syndrome, we have 2 theories. One says that it is related to the progesterone or either progestogens if the patient is on exogenous progestogens. The other theory is that it is related to the brain chemicals like serotonin and GABA, that is gamma aminobutyric acid. So that is why in the treatment, I will be talking about the treatment later. That is why in the treatment we also use the SSRIs, that is selective serotonin reuptake inhibitors. So let's look briefly at the management of premenstrual syndrome, because this is a topic that the most of the medical students and the residents get mixed up, the management. Okay, if you look at the management, we can talk about it in several stages. I will first talk about it and then we'll show you a small column table, a small table that I made about it. So as a first line treatment, we ask the patient to go through exercises, specifically aerobic exercises, and then we can direct them for cognitive behavioral therapy. That is very useful as a first line treatment. And also we can start them on vitamin B6 supplementation, and then also as a first line treatment we can start the patient on COCP, that is combined oral contraceptive pills. Then also you have to be it is important that in the combined contraceptive pill that you are using, the progesterone should be a drospirenone preferably, because if we use something like northestrone or levonorgestrel containing combined oral contraceptive pills, that will again exacerbate her symptoms, because those progestogens are related to PMS. And also, as a first line, we can use low dose SSRIs, for an example, citalopram or escitalopram. It could be used either continuously or only during the luteal phase. And also, I talk about the COCPs, that also can be either used continuously or cyclically. And then that is the first line management. If the patient is poorly responding to the first line management after few months, after 2-3 months of treatment, we can go for the second line treatment. The second line treatment will be usually estradiol patches, and also we have to, when we are using an estrogen supplementation continuously, we have to add this form of progesterone. So in that case, in the second line management, the progesterone that we are using is either micronized progesterone per vaginally or orally, or we can put her under a levonorgestrel IUS such as Mirena. So we can use that together with the estradiol patches. So that's one of the hormonal second line managements. Or either if she had been on the SSRI previously, a low dose SSRI, we can increase the dose into a higher dose, and we can give it in a continuous basis, or we can provide the SSRI only during the luteal phase. So the fact that the SSRIs can be used as both as first line and second line is clear now, but whether it's first line or second line depends on the dose that we are using. If it is a low dose like 10 milligram, it will be first line. If it's a high dose like 20 to 40 milligram, that will be a second line management. So if you look at the third line management, that will be GnRH analogs. And when you are using the GnRH analogs more than around 3 months, we have to give her add back HRT. And also in that case also, when you are giving her HRT, we have to be careful that the progesterone is either micronized progesterone, and it's not a progestogen like levonorgestrel, which could bring back her symptoms. So there's another instance where we use the GnRH analogs. That is, here we talked about the management, but also in the diagnosis, if the symptom diary is not clear and it's not it is inconclusive, where you can't identify whether it is premenstrual syndrome or whether it is exacerbation of the previously existing disorder, then if it is not clear, we can put through GnRH analog for 3 months duration and see if she is responding to that. If she is responding to that, we can clearly diagnose the premenstrual syndrome. And if she in the management, if she is put under all 3 levels, the first line management, second line management, and the third line management, but still she is not satisfied by the management outcomes, and also she should show some form of good response to the GnRH analog, because the fourth line management will be surgical removal of the bilateral ovaries and uterus and giving her HRT. So before embarking on that fourth line treatment, that is the definitive management, we have to make sure that she answers well to the GnRH analogs, because that is the only only treatment that can prove that the surgery that she is undergoing is going to give her a good result. Otherwise, we are putting the patient through making the patient to go through a surgical intervention where the result will not be that satisfactory. As it is the last stage of the management, we must put her through GnRH analogs for at least 3 months duration and see the response before putting her for surgery. So that is the summary of the management of premenstrual syndrome. So I would like to take any questions that you have to ask about it. I will show you the management which I wrote on this whiteboard for it to be easy for you to remember it. This is the first line management, which consists of exercise, cognitive behavioral therapy, vitamin B6, COCP new generation with consist in drospirenone, and continuous or luteal phase SSRI at a low dose. And then the second line will be estradiol patches plus micronized progesterone or levonorgestrel IUS, or else we can go for high dose SSRIs. That again can be continuous or luteal phase. And the third line, that is GnRH analog plus add-back therapy. But the problem with this is you can't put the patient on GnRH analogs for a long time. So the last resort will be surgical management plus HRT. As I said before going for a surgical management, which is a definitive management, we have to put her through GnRH analogs. So I am more than happy to answer any questions you have to ask related to premenstrual syndrome. Thank you.